Hello, I'm Patrick Muck. I'm the chief of the Division of Vascular Surgery at Tri-Health Good Samaritan Hospital in Cincinnati, Ohio. I'd like to thank the Venus Edge contributors, as well as my good friend Mackey's for the opportunity to join you. Here's my disclosures. This is Ruth. Ruth is a very sweet 51-year-old female, works at one of our local gas stations. She came in with a 6-day history of left lower extremity pain and swelling. We still follow the early thrombus removal strategies for acute deep vein thrombosis and the clinical practice guidelines of the SVS and the American Venous Forum. I think we would all agree that this document that came out in 2012 needs to be updated with some of the exciting technology I'm going to share with you here shortly. That document from 2012 states that folks with an iliofemoral DVT that's 2 to 3 weeks in duration with a low bleeding risk and in experienced centers should undergo pharmacomechanical thrombectomy. As I said, I'm going to highlight some new technology that is really exciting and is super beneficial to our patients today. Across the Atlantic, our European colleagues have certainly already embraced these new technologies. The ESVS came out with this clinical practice guidelines on the management of venous thrombosis. And recommendation 34 states that in selected patients with symptomatic ilio deep vein thrombosis, early thrombus removal strategies should be considered. Of course, at the end of the day, you have to individualize. Perhaps we're going to be a little bit more aggressive with the lady on the left, as opposed to the lady on the right. We probably would be a little bit more conservative. So you really have to take each patient and individualize their therapy to match their demographics. In Cincinnati, as in many centers, we strive for single session therapy. Oftentimes we'll do a high posterior tibial or a popliteal stick, use anywhere from a 7 to 13 French sheath. Once you cross your thrombus with a hydrophilic catheter and wire, we then go on to use a 260 Amplats, employ our new VTE devices. You really only need about 60 minutes, little to no TPA, certainly need IVUS to identify the underlying bad iliac lesions that are often uncovered, and then an FDA-approved stent, and then typically just a purse string, although we have used the Cardiva Vascade 12 French device. For this particular situation, we used a device that we pretty much use weekly. We used a clot retriever from Inari. On the top left, you see the collection bag with the coring element, and at the bottom, you see the nitinol kind of funnel at the end of the sheath that allows for the thrombus to be extracted through this 13 French system. Here to the left, you see the collection bag, and then here is the coring element that we use. The image to the right highlights the fact that you do need to have the Amplats up into the IJ, as it's a long device. So simply just place it up into the IJ before you start to deliver therapy. On the left is just a picture of what it looks like. Here you can see again the funnel that comes out at the end of the sheath that helps to collect the thrombus. Here you can see also you're able to aspirate. Here we have up in the right, the access and the popliteal. And then again, at the bottom here, you have your nitinol basket with the coring element. And what this allows is for a complete wall-to-wall thrombectomy. What you're going to do is you're going to line the device up. You're going to work in 4 different quadrants. So typically within 4 passes, this is what you're going to get out. And again, it's wall-to-wall complete thrombectomy. Here at the top left, you can see the coring element is where we're coming through the iliofemoral segment here. And again, this is what it looks like before and after. And this is what we get, what's extracted on the back table. To the left, again, now we're done with the iliac system. Now we're coming through the fem-pop system. And to your right, again, what you see is wall-to-wall complete thrombectomy essentially every time. Once you're done with your thrombectomy, as I mentioned, you need IVUS. You then need an FDA-approved stent. You don't need lytics anymore. That's why the 2012 AVF SVS guidelines need to be updated, is because of devices such as this. Once you're done with your thrombectomy, then you're going to land your FDA-approved venous stent. Here's a Abre that we landed right on the iliocable confluence. So we're not jailing the contralateral side. And at the end, access management, as I mentioned, typically it's just a purse string, wrap it with an ACE wrap here with some 4x4. Sometimes we do use the Fastcade device, the MVP, that oftentimes the EP folks are using in the cardiac cath lab. So here's what we have for Ruth. We have lytic-free, single session, complete therapy. Here's an excellent radiographic result with our Abre stent. You can see it's tapered into the external. This is 100 length. Next time, not next time, pretty much all the time now, we use a 120 or longer. So you have excellent radiographic results. Here's our incredible IVUS results. Again, stent, nice concentric, good aspect ratio. And then you have radiographic, you have IVUS, and then you have clinical results with, here's Ruth, a couple weeks out. Very happy. Managed her with 4 weeks of Lovenox, then transitioned her to a DOAC, and she did incredible. So folks, today, newer VT devices are here. Single session DVT therapy is here. Bloodless thrombectomy offered by Inari is here, and I appreciate your time. And I'll be happy to take any questions from Mackey's. Thanks so much.
Well, Patrick, I really enjoyed your case, and I need to thank you for your contribution in Venus Edge. Looking at your case again, it is obvious that mechanical thrombectomy has changed the rules in deep venous interventions. I enjoyed the result on Ruth, and you can tell from her last picture with you that she was very satisfied. Seeing patients like her, I really want to see the guidelines changing. And as you pointed out, we should be expecting the Society for Vascular Surgery to come up with updated guidelines, since we haven't seen anything new since 2012. And the European guidelines have already embraced these catheter interventions. So I have a few questions for you. I will start with the patients you decide to intervene on. How long are you going to wait before you pull the trigger?
Yeah, that's a great question. You know, I remember being at the Midwest Vascular a few weeks ago, and the folks up in Michigan are perhaps a little more conservative than we are. To me, every patient you individualize, and either you're going to embrace the open vein hypothesis, and the sooner you embrace that, or you recommend that therapy for the patient, I think the sooner the better. So we really don't wait. I do know that some centers will give folks 3 to 5 days to see if they're truly still symptomatic. But to me, it's not about the short term. It's about the long term. It's about cleaning that vein out, removing the thrombus, removing the inflammation, and removing the potential, or at least minimizing, for long-term valvular dysfunction. So the short answer to that is, once we look at the patient and we individualize, if we determine we're going to treat, there's no reason to wait, at least in our practice here in Cincinnati.
Well, I will fully agree with you. I used to say that I wait 48 hours on heparin to see how they behave. But if I have a good risk patient, and I will present him or her the option, and I will intervene within 24 hours. So I'm full up with you. And then you presented a case of mechanical thrombectomy, and I agree with you that most of our patients can have an intervention without lytics. Yet, I don't think that lytics are completely out of the game. So I would like to ask you, do you still use lytics in any of your patients, either within the single session or considering lysing them for 6 to 8 hours before embarking for your eventual thrombectomy?
Yeah, that's a good question. For us, if it's truly iliofemoral, I think that the current data, and I think the accruing data, is going to show that you really don't need lytics for these folks, especially with a device like ClotTriever, where it's legitimately wall-to-wall thrombectomy. So I think for iliofemoral, we really don't need them. And I think even if you extend it out past a couple of weeks, I still don't think you're going to need it. This device works wall to wall. I think the folks that we all still struggle with are the occluded IVC filters. And I think those are the folks that you might benefit with a short 6 to 8 hour bursts with bilateral catheters from the popliteal and trying to clean out that filter. And then from there, you can always bring, as you know all too well, you can bring ClotTriever up and over and do it from each side, do it bilaterally. So I think that the answer is that occluded IVC filters perhaps still benefit from a short burst of concentrated thrombolysis, but not iliofemorals. I think we're going to see that we're going to be treating people further out than the current SVS and AVF guidelines of 2 to 3 weeks.
Yes, and that was actually my next question. With the Inari technology, specifically the ClotTriever concept, is very powerful in removing the clot. So you think we can open up the window of 2 weeks, extended now up to 30 days for removing clot? Or we are overdoing it?
I think that, you know, at the end of the day, not to sound too cavalier, but it's just a large 13 French IV, you know, that's really what it is. And we're able to pull out so much thrombus that I think that we will see the guidelines extend out to perhaps, you know, 4 to 6 weeks. However, being researchers, as you and I are, we both know that at this point we need to accrue data before we can recommend that. But I think in years to come, without a doubt, you know, think about it. Where the heck did the SVS and AVF even come up with 2 to 3 weeks in anyways? Like, I don't know where that came from. Is that from the Venous registry data? Did somebody just arbitrarily make it up? I don't know, but I think we need to continue to accrue data to show that this is, you know, that these interventions are safe, which is what they are. We're not exposing folks to thrombolytics, which is really the Achilles heel of those prior pharmacomechanical thrombectomy interventions.
Exactly. And my final question, you presented ClotTriever, and I will agree, it's a good option for the majority of our patients. Yet, as with all devices, some patients are better candidates than others. In simple words, do you think that there are patients that would not be suited for the ClotTriever device? And which are those? Any words of wisdom?
Yeah, it's a good question. I think folks who, in our practice in Cincinnati, folks that we probably shy away from it currently would be the occluded filter, even though, as we mentioned, you can go up and over and clear out the majority of it. But I think, you know, an occluded filter would be one. A freshly placed venous stent perhaps would be another one if, for whatever reason, the patient was non-compliant or rethrombosed, which fortunately doesn't happen that often, but I would think that would be another time. And then I do remember, if you remember, I think it was the AVF meeting right when COVID was the public health emergency was hitting. I think if I remember, there was a paper by Peter Pappas or one of the groups up east that recognized that folks who had prior laminectomies and you know, spinal surgeries and decompressions, if you mobilize the left common iliac vein, perhaps you can develop some scar tissue and narrow the common iliac vein. I don't know if that was ever published, but I do remember that paper. So I in my mind, I'd be thinking about that. And those would probably be the 3 biggest reasons. The only other time I can think of is if somebody had a narrowed SVC or something along those lines where you couldn't park an Amplats up in the IJ, but that's a relative indication, really.
I can tell you, actually, I can share my experience. I used it in an aplastic IVC that was thrombosed, and I was surprised to see how well it could actually work through without causing any problem. How about a small popliteal vein? Would this be any concern?
It's always a concern, of course. However, both you and I have gone through the smaller, the short sapness. I don't think I've done high posterior tibial with this device, but I've definitely gone through the SSV for this. So I don't think it's, I think it's, again, a relative indication. And I think more times than not, the device is going to go.
Well, I will agree with that. I have been using ClotTriever for the past couple of years with excellent results. And again, we very much enjoyed your case. Thank you very much for your words of wisdom, and thank you for contributing in Venus Edge.
Hey, Mac, it's always good seeing you. Good luck in Greece. And can't wait to catch up with you live sometime soon.
Thank you, Patrick.
All right. See you, buddy.